Good evening, and welcome to this edition of the Alpha Phi Alpha Incorporated Surgeon General's Initiative webinar. I am Dr. Langston Smith, Deputy Surgeon General for Dental Health. And on behalf of our General President, Brother Willis Lonzo III, our Board of Directors, our Surgeon General, Brother Dr. Jeffrey Sterling, and the team of Deputy Surgeons General, welcome. Tonight, we will have a conversation between two pediatric dentists on topics that are significant and informative of the oral health care of infants, children, and adolescents. If you have questions that you would like for them to discuss, please put them in the comment box and they will be asked during the conversation. I would also ask that you mute your devices and we will proceed. Tonight, our panelists are Dr. Christopher Chance. Dr. Chance received his dental degree from the University of Kentucky in Lexington, Kentucky, and completed residency in pediatric dentistry at Case Western Reserve University School of Dental Medicine in Cleveland, Ohio. Dr. Chance is board certified by the American Board of Pediatric Dentistry and is in private practice in Houston, Texas. Dr. Chance is an avid golfer and a member of Alpha Phi Alpha Fraternity Incorporated. Welcome, Dr. Chance.
Thank you.
Our second panelist, Dr. Rodney Jackson. Dr. Jackson received his dental degree from the University of Kentucky also, and completed his residency in pediatric dentistry at the Chandler Medical Center at the University of Kentucky in Lexington. He is board certified by the American Board of Pediatric Dentistry and is in private practice in Lexington, Kentucky. Dr. Jackson is involved in leadership positions in several organized dentistry organizations and is a member of Alpha Phi Alpha Fraternity Incorporated. Welcome, Dr. Jackson. I must say that it is an honor to share tonight's webinar platform with two of my fellow University of Kentucky alums. So this is a Go Blue opportunity tonight. Okay. The American Dental Association recognizes 12 specialties. Pediatric dentistry is that specialty that involves primary, comprehensive, and oral health care for infants, children, and adolescents, and even for those with special needs. The care of pediatric dentists goes beyond just the clinical aspects of treating cases because they seek to create a comfortable experience for their patients. And with that, I will now throw out the first question for our panelists to discuss and ask them if they will take a step further by telling us just what pediatric dentistry is and the parameters of care practiced by pediatric dentists. So have at it, Drs. Chance and Jackson.
Chris, you can go first.
Appreciate it. So first off, I want to thank everyone for having us. I'm excited about this discussion. And so with pediatric dentistry, it encompasses a wide scope in regards to dental care, treatment, education for kids and their parents in regards to how to take care of the teeth and being careful about in regards to traumas and really setting them up for lifelong health. I kind of view it as if we're able to have positive experiences in the dental chair at a young age, they will become older adults who have no issues going to the dentist and taking care of themselves as well. So I think it's all encompassing. It's very important and very, very integral in even the next stages of life as they get older.
I'll kind of piggyback on that. I think I initially went into dentistry primarily for the preventative aspect of dentistry. And I think pediatric dentistry, being able to be involved in a patient's life at the onset, is the most effective we can be as far as preventative medicine is concerned. If you can teach those proper skills to the patients and the parents as well, then hopefully we'll be able to eliminate a lot of the issues that they have in the future.
One of the things that I, as a practicing endodontist, experienced was phobias. One of the things that patients always said to me, not always, but sometimes said to me is, I don't like dentists. What does this do for you as a pediatric dentist to have allay those apprehensions and those phobias beginning at a young age?
I take it on as a challenge. I mean,
Yes.
That's one of my favorite things. If a patient comes in and is really apprehensive or nervous, I think just the environment in most pediatric offices, they are geared towards making children comfortable. And fear, oftentimes most fears are stemmed at an early age. So if we can help them jump over those hurdles, which might potentially result in the fear at an early age, then it's more beneficial for the patient in the long run. When the patient sits down, you're taught in residency to really get to the patient's level, try to make them feel comfortable, to enable them to be able to enable you to be able to do the work. I mean, dentistry is very invasive. You're in someone's personal space. And for a pediatric patient, that can be overwhelming initially. But as long as they're comfortable enough with you to let you invade their space and to provide the best care possible to them, then they tend to come around and not be a dental phobic as they get older.
Okay.
Absolutely. I agree. And in regards to the challenge part of it, it's our favorite part. We're able to turn like something that's seemingly scary, a time where, like Dr. Jackson said, you're vulnerable as a child, and turn that into a position of power once they reach that milestone. You get them through their procedure, or they get more comfortable in a time where they were scared. The light that kind of comes out of them is really what it's all about. Is really seeing them grow up right in your chair, and it kind of also goes into with the parents too, because the parents can sometimes kind of guide a child into maybe feeling a little bit scared, not on purpose or anything like that, but maybe from experiences that they've had as well. And so I kind of take, I'm sure Dr. Jackson as well, because I learned honestly from him. And so we take that on as a challenge for the parent as well, to kind of turn their phobias around. And sometimes even after we're done with the procedure, the parent, talks to us and say, hey, do you know a dentist? Because, I haven't been in so long, but you made it seem so comfortable. Someone like you. And so that can be powerful as well for the whole family.
Okay. Well, thank you very much for talking about that aspect. Now, tell me about training, your specialty training. How are you trained? Tell us about the people out there might want to know, well, these are pediatric dentists. What makes them a pediatric dentist? How is their training? So I know from your bios, so good institution. So tell us about it.
Yeah. So after finishing 4 years of undergrad, I majored in agricultural biotechnology. Honestly, you can really major in just about anything that you like in regards to your undergraduate career, just getting the prerequisites for dental school. Dental school at University of Kentucky. It was great because there was pediatric dentists and a pediatric dental program that's there that you're able to, learn a lot about pediatrics and specifics. And so not only that, there were experiences like what's called Saturday morning dental clinic. That really is what prompted me to want to become a dentist, honestly. The Saturday morning dental clinic was a student-run clinic where they treated only kids. And it'd be like one Saturday a month or so. And it was completely student-run, dental students. And that was a time for me to, ask questions and learn about what the process was. I learned from Dr. Jackson going to his office when I think it was in high school after the Saturday morning clinic. And he kind of taught me how owning a practice was. But the Saturday morning clinic taught me the process of what it's like to learn and what it's like to fall in love with the grind, fall in love with the not so glamorous parts. And so after that, and deciding that I ultimately want to do pediatrics, went to Case Western in Cleveland, Ohio, and Dr. Gerald Ferretti was my director. And it's a pretty intense program, as the one in University of Kentucky is as well. But very intense program. We are on call. We rotate call for all the residents. Where, let's say, after hours there would be an emergency. Kid falls down and hurts themselves, chips a tooth, knocks a tooth out, something like that. All hours of the day in the cold Cleveland weather, getting up and going to the Rainbow Babies Children's Hospital, and even it kind of taught me as that no matter how you feel, your circumstances, every child deserves the best version of yourself. I mean, everyone does, but definitely the children. And didn't matter what time it was, how cold it was, or anything like that. It kind of really just taught me how to put everything else aside and focus on the child at the time. And so we learn a lot. We learn about craniofacial anomalies. We learn about almost everything that you will and won't see in the private practice, some of the most severe cases of things. And so it really prepares you for anything that comes through your doors.
I always liken the residencies. It's additional school because there are didactic or educational classes that you're taking, but the vast majority of them are your experiences are clinical, and it just prepares you to be able to be a pediatric dental provider. A lot of people say, I have parents that will ask me, like, what is the difference between a pediatric dentist and a normal dentist? I say, I equate it to the difference between a family practice physician and a pediatrician. Pediatricians go to residency to learn to treat pediatric patients. Pediatric dentists do the same exact thing. So those additional 2-3 years, however long the programs are, depending on where you go, are teaching you things about growth and development, orthodontics, craniofacial anomalies. You're learning about child psychology classes to be able to relate to the children. You're learning practice and management a little bit, but the vast majority is geared to teaching you to be the best pediatric dental care provider that you can be.
Okay. Well, thank you very much for that insight into the training background and your preparation as a pediatric dentist. And so now let's get into the clinical aspects. Let's start at the beginning. What concerns should parents have about their unborn child's teeth and their unborn child's oral health? And what can they do to ensure good oral health for those children before the child is born?
Well, I liken to the fact that most of the time it's based on dental knowledge or dental education. So if you have parents who know about the oral cavity and the oral condition and how to take care of it, then the likelihood of their children following in their footsteps is so much higher. We talk about access to care and different socioeconomical issues. What you do with your mouth is probably what you're going to do with your child's mouth. So a lot of times when women are pregnant with the children, it's extremely important for them to have a well-balanced diet, be taking their prenatal vitamins, be getting the proper prenatal screenings by their OBGYN, because, for instance, cleft lip and palate can be detected relatively early in a pregnancy. That's something you want to know if your child is going to be born with cleft lip and palate. So the appropriate team can be assembled as soon as the patient is born, as soon as the child is born, to start addressing that issue. When teeth are coming in, you want to make sure that they're brushing them and that they're giving them a well-balanced diet with all the vitamins and minerals that they're supposed to have. So a lot of things that parents need to take into consideration in that prenatal period that's going to dramatically affect the health of their children once they're born.
And also having the idea that what comes when a child is born, those baby teeth, they are important. Sometimes we'll have parents say, well, do we have to fix that? They're just baby teeth. Is that important? They're just baby teeth. But kind of having in your mind before your child is born that everything about that child is important, especially their teeth, because it sets them up for so much, good or bad in the future. And it's not until something kind of goes wrong, then you kind of realize how important it is. So kind of having the mindset that when, you're in the process of having the child, you're going to take care of all of the child, including their teeth.
Okay. But Dr. Chance, you brought up a question that I have later on, but since you just brought it up, I'm going to throw it out there right now.
Sure.
Oftentimes parents will say if a child develops decay on their primary teeth, they will say, "Oh, it's just a primary teeth. Just let it stay there. No need to worry about it." What do you say to that?
My first thought is really trying to talk to them in regards to what can happen if we just leave it alone, right? Some of it depends on the age of the child, how big it is, and things like that, whether we do, in fact, just leave it alone, watch it for a little while. But just in the grand scheme of things, it's kind of understanding that if a child is not able to really have a means of taking care of their own teeth, and we're making sure that we're brushing, we're flossing and everything, how are we going to all of a sudden assume that the child is going to learn how to do that when they have their adult teeth? And it takes all of us. And for me personally, I don't judge. Like if someone says that, it's just an opportunity to kind of talk to them about their importance, and just a little bit of tweaking in their oral hygiene or their diet can make a big difference. And them seeing that difference can also kind of put it in real terms. And I show them pictures of what happens if it goes wrong. I have examples of what happens that we have to do to fix certain teeth. And it's not the fact that they would rather something poorly happen to their child. It's more so trying to weigh the importance. And if they don't know the importance, part of it is because of the education. It's our job to do that, to change that. So I just see it as an opportunity. And it's kind of a way to really set yourself apart and kind of open their eyes to what's possible and what can be to come.
And I think the issue too, that especially with first-time parents, most people don't remember when they lost their teeth. So I think there's a general consensus, well, not a general, but a lot of people think that most kids lose their baby teeth at age 7 or 8. Well, you are losing your front baby teeth from 5 to 7 or 8. But your molars, your baby molars in the back, or some kids are 12, 13 before they lose those teeth. Mm-hmm. So it's extremely important you take care of them while they're there. And if there is an issue, fix it while it's a small issue. And the treatment is much less invasive to fix it while it's small. But by all means, fix it, because it's important that they have those teeth to be able to develop properly, also to be able to eat without any issues, and also so they're not in pain or discomfort while they're living their daily lives.
Mm-hmm. Is there any relationship between maintaining their primary teeth so that how does that relate to space for the permanent teeth? Is there a relation? Because some people say, well, they're going to fall out anyway, just let them fall out. They're going to lose them anyway, just let them fall out. But, maintaining those teeth those primary teeth as long as possible is very important. So what do you say to parents about that?
I'll have parents that they'll say, oh, it's just a baby tooth, can we just pull it? And I explain to them that baby teeth have roots for a reason. Mm-hmm. The adult teeth are literally right below those roots. And oftentimes that root provides a pathway of eruption or a way for the teeth to come into the mouth in the appropriate space. So oftentimes, if we extract the tooth prematurely, you ideally want to put something called a spacer back there to hold the space open so that the adult tooth will come in the proper position. If you don't do the space, or even when you do the spacer, that root space, the bone that was previously occupied by the root is filling with solid alveolus or bone. So it's harder for the adult teeth to come in. There's no direct path for them to follow. So it sets up a whole myriad of different issues that can happen if a tooth is lost prematurely. But we as pediatric dentists and orthodontists, we have ways of kind of helping things progress in a more favorable manner if that does have to occur. But everything serves its purpose.
Okay. All right. Let's move on to, I kind of got ahead of myself on that one, but there are a lot of concerns about the eruption pattern. I know there's a rule called the 7+4 rule out there, something like that. And some people are concerned with early eruptions, delayed eruptions, and what about developmental anomalies that parents have that they should see the dentist about, or questions they may have to address those issues?
Yeah, absolutely. So you alluded to the 7+4 rule, and basically means that by 7 months you should have your first baby tooth, and then 4 months after that you should have 4. And then 4 months after that, you should have 8. To be honest, everyone's kind of a little bit on their own timetable. So I don't get too concerned unless it's very early. Like if you got a tooth when they're born, right when they're born, like with a tooth, or let's say 30 days after or less than 3 months old, then it can be a little bit of a concern because it could rub against the tongue and then kind of have a little bit of a sore underneath the tongue because it's there too early, and kind of interferes with nursing. Outside of that, if it comes a little bit later, I have some patients, they say, they're almost 10 months, 11 months, they don't have a tooth yet. I typically say, let's continue to keep watching. And when I take a look, you can kind of see them just underneath the gums. And a lot of times that'll happen. And all of a sudden they have 4 at one time. I wouldn't be too concerned unless they're like a year and a half, 2 years, and they have no teeth. But typically not everybody can be on a timetable, as let's say even another sibling. And so it's always important, if you're concerned, come to the dentist and we'll take a look and kind of go from there.
Okay.
That's funny. That's definitely a concern. My roommate in dental school kept complaining because their child didn't have teeth. Mm-hmm. And this patient, she was 14 months before she got her first tooth. And I saw my roommate's older son as a patient, and his time frame was he was right on schedule with everything. And she was like, I still understand why she doesn't have teeth. And I said, everyone's different, even though they're siblings. Genetically, there's genetic differences with everyone. But believe me, they are. And just like Dr. Chan said, you could see them up under the gums. And when they came in, I mean, it was a massive exodus of the teeth out of the gums. They all came in pretty quickly. And she was like, yeah, you told me they were coming in. But again, I try to reassure the parents not to stress. I do ask probing questions as far as like family history of people missing teeth. And most oftentimes there's not a history of it. It's a concerned parent.
Okay. All right. So now we've got the teeth in the mouth. When should they take the child for his first dental appointment? And then how often after that? And why is that?
Well, the American Academy of Pediatric Dentistry, as well as the American Academy of Pediatric Medicine, recommend within establishing what we call a dental home within 6 months after the first tooth erupts. So on average, the first tooth eruption comes in around 6 or 7 months of age. And, by age 1, hopefully they brought the patient in for their first appointment. Oftentimes when they come in for the first appointment, we're answering questions the parents have, because again, they're oftentimes if it's the first child, they have tons of questions. And we do what we call anticipatory guidance. And that teaches the parents, we review nutrition, non-nutritive habits like pacifiers, thumb habits, things of that nature, brushing and hygiene instructions, and then just educating the parent about the do's and don'ts of taking care of their children's teeth.
Okay. Many parents worry about taking their children to the dentist for dental appointments because they are concerned about x-rays, and that x-rays may not be safe for their children. What do you say to this concern?
Well, yeah, I would say that according to the American Academy of Pediatric Dentistry, it's all about measured the most reasonable amount necessary to diagnose what it is we need to take a look at. So understandably, when you're thinking x-rays and you're thinking something that could be, over time compounding detrimental to one's health, I think that dental x-rays are probably about 1% of the overall medical x-rays exposure that you may get, but also one x-ray may be similar to maybe an hour or so outside. We try not to take many x-rays at all. We don't start until about 3 years old if their teeth are even close together. So, if the teeth are close together and they're 3, then we'll take x-rays. But if we see nothing, we probably won't take some again for another year and a half. But the x-ray amount is so minimal and then the amount that we take is minimal, only the necessary, that it is not as much of an issue as maybe let on or someone may believe, given how they think that x-rays, how strong x-rays can be. And even so, using digital x-rays can also lessen the amount of x-ray exposure because of how fast they're exposed. So technology and the amount or least amount that we give help reduce the amount of x-ray exposure that we may expose to children over time.
And I'm glad you mentioned the digital x-ray because, I remember, I started practicing right when digital x-ray came into the popularity. But I remember as a child going to the dentist and sitting in the chair, and the exposure length of the X-ray beam just seemed so excessive. There's no telling how much radiation people used to get, or even the dentists or the assistants or hygienists were exposed to back in the day. But with the advent of new technology, the exposure is so minimal that I don't even, it's not even it's a non, it doesn't even matter at this point. It's so minute that it's not a major concern anymore.
There are some other, you can talk about technology. There are also other units that can use, like say an iTero or like an intraoral camera that has the capability to detect, cavities in a sense. I probably wouldn't use it instead of X-rays, but it could be kind of an adjunct to use in the meantime, or if you're watching something and parents are concerned about exposure. There are other technologies that don't use X-rays that can, and it's also in different colors so that the parents and the kid can see exactly what's going on, and being visual is also really helpful. They can really see it.
All right, so, from the time I was in dental school at the University of Kentucky until now, yes, it has changed drastically, and I would say for the good.
Yes.
Okay. Now, in 1958, fluoride and the fluoridation of water supply was introduced. And as a result of that, we saw a drastic decrease in tooth decay. So as we look today, how important is fluoride for the oral health of children? And let's talk about the sources of fluoride and whether, and there's a lot of conflict, controversy maybe, between fluoridated communities and cities maintaining fluoridated water. How do you address that?
I mean, I try to educate the parents as much as possible with internet and social media and the massive amount of information that people are exposed to. Everyone can draw a conclusion, and any conclusion that can be drawn, you can always find something else to negate that conclusion that they've drawn. So I'll start it with that. It's really popular in a lot of, especially in California, they're trying to do away with a lot of the fluoridation programs. Fortunately, here in Kentucky, we still have it. I myself am a fan of fluoride, especially considering the fact that in Kentucky, we have a higher caries risk here. So any additional thing that I can do to give the parent and the patient that will help prevent issues in the future, I find as a positive. I just educate them on what the purpose of fluoride is, let them know it's a naturally occurring element that we use, what it actually does to help mineralize the teeth and prevent decay from forming. And even after I give my whole spiel, sometimes parents still will say, well, thank you, Dr. Jackson, but we just want to avoid it. And ultimately, they are the decision maker for their child. I have to honor what they say, but I find fluoride to be extremely beneficial.
I agree. In those situations, I stop. I don't argue. I just lay out the information based on data, and then if you don't want fluoride, there's no convincing, and from my part, it's more so, okay, that's perfectly fine. Here's what I would need for you to do if we don't have something like fluoride. Increase hygiene, improve diet. We can even check in a few months to take a look and see how that's going. Increase the amount of flossing that we're doing, and there's options, hydroxyapatite, toothpaste and mouth rinses and things like that. That's an alternative to fluoride if they so choose. And then it's giving them options at this point. I'm not really. It's hard to compete when you have something in your hand or on your lap typing that you can see every day that's counteracting what it is you're saying, and you kind of give your spiel and then let them do with it what they may. But it's a daily conversation, but it's all about information as much as possible, and just let them know we're all on the same team, and we're trying to find ways to get them to success, which is health, and however way we do that, it's fine with me.
Okay, but back in 1958, when we went to fluoridated water supply, we didn't have fluoride toothpaste, didn't have fluoride rinses, and we didn't have fluoride supplements. And with the now parents using fluoridated toothpaste. They're using the rinses. Is there a fear maybe of over-fluoridation, and to the point that we get a area? Oh, and there's also natural fluoridation in some areas of the country.
Mm-hmm.
So what about fluorosis and oversupply of fluoride?
I actually had a patient that had fluorosis. They have well water here in Kentucky. They're not on the municipal water system. And the parents brought the patient in, and I wasn't exactly sure what it was, but I'd never seen it personally in my life. You've seen it in textbooks. So I just recommended that they go get their water tested, and the levels of fluoride in their water system was extremely high because, again, it's a naturally occurring element. But with fluorides, not necessarily supplementation, but fluoride in drinking water, that's more so systemic. It's not topical. The toothpaste that we're using is just on the teeth. I think it's extremely important for you to have a systemic source of fluoride, especially in the developing dentition. Children who don't have the permanent teeth in, because as the teeth are forming down in the follicle, all the vitamins and minerals, the shape of the teeth is being decided upon at that point. And the fluoride that they're ingesting that's systemic is actually being laid in layers into their teeth that are currently forming, so that when they come in, they have a fluoride-rich layer on the surface.
And I'm very glad you pointed that out, Dr. Jackson, because understanding the systemic availability and ingestion of fluoride is quite different than the topical application, and the benefit is much different. So,
Yes.
But your media folks don't address that.
No.
So I'm glad you pointed that out. Okay, so let's talk now about medical conditions that might affect the oral health and teeth of children. Are there any that you would, any medical conditions that affect oral health of children and the development of the teeth?
Mm-hmm. No, absolutely. Some of the first, conditions that we might see, be it that is benign, but sometimes we'll see coming into the office would be kind of like these white kind of almost like sacs, white cysts that kind of come around the roof of the mouth or along the gums before the teeth even come in. And, those are normally occurring, I'm going to say phenomenon, but normally occurring ailments that happen on the gums and tend to go away over time. But as teeth kind of come in, sometimes teeth can look a little bit more green. That means they may have an issue with their bile or their bile duct. It may be a little bit more red or purple. They may have an issue with their bilirubin. There are other issues with teeth, where they're having too many teeth or not enough teeth. Teeth are misshapen or fused together. There are times where even, let's say someone was, this didn't directly affect teeth, but if someone was low on iron when they were very young and they may need iron supplements, sometimes the iron supplements being placed on the teeth can cause teeth to be discolored and more of a darker color. So if it's not necessarily just the teeth because of an ailment, it could be the medication like tetracycline or something like that. I had a patient, a couple actually, who had what's called hypophosphatasia, which they had teeth come in fairly normally, and right around 2 or so, all of a sudden they come in because the tooth just literally falls out. Full root and everything. They're not supposed to fall out, as Dr. Jackson mentioned earlier, until about 5.5, 6 years old, maybe even 7. But it falls out full root, no blood, basically, just while playing. And it just means that the area that's around where the tooth and the bone meet, there are disturbances in the bone that just allows those teeth to come out, and it's an overall systemic, issue. And so there's a couple times where I was able to diagnose or help diagnose that. So there's a lot of things that can kind of come about with that shows themselves dentally, which is important, is to come early to the dentist at the recommended times.
And more so than just the teeth. You have, like, a lot of times if you have a patient that has Down syndrome, they tend to have a certain facial structure. So you have to deal with the different dental issues that you might have based on the skeletal structure of their face. And there are a wide variety of different syndromes that have a clinical manifestation in the face and the mouth that will impact the child's overall oral health.
Absolutely. And then one in particular that sometimes I think we may need to talk more about, but Sickle cell. It's times that you don't really even see or know that something's wrong necessarily, but the red blood cells can sickle inside the teeth. So you have pain inside the teeth, and there's no cavity, there's no fracture, there's nothing. And then, if not necessarily educated in that, and you may do treatment on teeth that are otherwise healthy, despite, the red blood cell sickling in there. So other things to consider as well.
Okay. All right. Well, thank you. And I'd just like to take a moment to say to our attendees out there, our viewers, if you have questions that you would like to pose to Dr. Chance or Dr. Jackson, please put them in the comment section, and we will get to them as we move along with this conversation. Earlier, you mentioned habits, and there are several habits that young kids get into. Thumb sucking and baby bottle syndrome, tongue thrusting, lip sucking, and the use of pacifiers. How do these habits interfere with the oral health of the children, and what do you do as a dentist to address these habits?
Well, the American Academy of Pediatric Dentistry gives us guidelines which we follow. And it's interesting because non-nutritive habits like pacifiers, there's no clear-cut delineation on when you should recommend patients stop it. I just had a discussion with the parent about this today. The patient was 4 years old, still using a pacifier. And the way I always present to my parents, the patients and the parents, is wherever the baby teeth are when they become loose or mobile, you can expect the adult teeth to come in and right around that same amount of space. So if you have a pacifier habit or a thumb habit, oftentimes it's going to make the top front teeth flare. Sometimes it'll make your bottom front teeth kind of collapse into the mouth. But more importantly, it's vaulting or causing your palate to have a higher arch, which will cause what we call posterior crossbite bilaterally or unilaterally. It's causing the front teeth to flare, and it's creating what we call an open bite, meaning that when patients bite or try to bite through something, their top and bottom teeth in the front don't meet because they have an open bite. So there are a lot of ramifications that can occur based on some of the habits that are established when they're really young. Like I said, when the first visit, we try to go over anticipatory guidance, going over non-nutritive habits, going over nutrition, letting parents know that children should not go to bed with a bottle of milk or juice or anything other than plain water, because at night you produce less saliva, you increase the likelihood of getting cavities. The teeth are being bathed in whatever solution that you have that has usually a fermentable carbohydrate. The bacteria that cause cavities use fermentable carbohydrates to create the acid which causes the cavity. So it's just a matter of educating the parents and the patients, if the patients are old enough and receptive enough to do it. But definitely just letting them know of the possible complications that the habits that they're currently doing, what it could occur in the future is most beneficial for the patient and the parent, but also in the patient's long well-being.
Absolutely. And, helping them find ways of removing them, those habits are important too. So sometimes, with the pacifiers, a lot of times coming out of a hospital, they give them the most, like the biggest pacifier. It's like, it's round. It's so it makes the kid's mouth so wide, and it allows for them, like Dr. Jackson said, to have an easier time to have a more narrow palate or an open bite. And so sometimes if the parents are nervous or worried about if a child is receptive to getting rid of their pacifier, we'll say, okay, well, we can either change the pacifier to something a little bit more like narrow at the base. Sometimes we call them orthodontic pacifiers. So the ones that are coming from the hospitals, they're just like wide from the base all the way. The more orthodontic ones are kind of narrow or more flat where the teeth come together. So it allows their teeth to come together a little bit better. It's probably wider for the palate to maybe shape it a little bit more wide. So it's not doesn't make the upper palate more narrow. And then once you get started, you kind of cut the very tip of the, do you do that, Dr. Jackson?
I just still do it. Yeah.
Cut the very tip of it, create a bigger hole. Then, every few days, cut a little bit more like calamari, just keep going, keep cutting. So that way, when they try to use it, it just doesn't work because there's no suction there. And then it's kind of the parents' job to figure out whether or not they want to replace it or not. But, and then, if it's a thumb sucking habit, then that the nail polish that is clear, it tastes disgusting. It's edible for that purpose. But honestly, lately these days, these kids don't care. They don't care what it tastes like now. So they're pretty focused. And so instead, there's some things like what's called the T guard. You put it on their hand. Sometimes it kind of has holes in it, so it's harder to have the suction. And incentives. Like I give out so much stuff to these kids to try to see if they can get, I'm not past bribery at all. So, and so whatever we can do to make that easier and help, then we'll do it. But, it saves the parent money. It saves the kid experiences that may be uncomfortable with having to have, orthodontics to widen their jaw back or braces at an earlier age, and things like that. Self-conscious about how their smile is. So, we try to address it as early as possible.
And I always tell the parents, if they complain, if they want to have to break, they're a little apprehensive with doing it. I say, you can either decide if you want to go through a couple nights of crying now or pay thousands of dollars to get the problem fixed when they're older. I mean, right. the decision, I'm here to provide the advice. It's up to you to heed my advice and do what you want to do.
Yeah.
Oh.
Well, thank you very much. Today, we see sports and athletics among young kids on an increase. Over the past 20 years, it's risen dramatically. And we see a lot of traumatic injuries. We see avulsions, fractures, lacerations. So number one, let's talk about children in sports and how they should protect their teeth. And then once we finish that, we'd like to get into how do we manage the emergencies that occur? And some of them occur from sports and others just from falls and what have you. But definitely we see fractures and avulsions and intrusions and what have you there. So let's talk about protecting the teeth during sports.
Absolutely. So one of the big things I tell, I ask kids is, if you play a sport, do you wear your mouth guard? It's huge. I mean, you may see professional athletes, they may have the mouth guard if they play football. It may be up in their face mask. If they play basketball, they may be chewing on it, or they don't have it with them or in the pocket or something like that. It's very important that they wear their mouth guards, because you just never know where there's an inadvertent elbow. There's some sports that is not typical to wear mouth guards, like baseball, which I see the most injuries with. But it's really kind of education of that too, being better discussion on how to field ground balls, how to field pop flies, and being careful and not having your bat, if you're walking around, your bat over your shoulder, turning around and accidentally hitting another kid. So that part is going to be kind of very important from the get-go. But, beginning quickly, having your number out in the community, or they know that, if there's an injury like that, they know who to call, is very important, so they can act quickly. If there's a tooth that got avulsed, which means comes out, let's see, fall down, hit their face, tooth out of their mouth. If it's a baby tooth, we don't recommend putting it back into the socket. The new adult tooth is up there, and we don't want to damage anything. So, I usually tell parents, take a picture of it, text it to our line. We'll talk to you about it and how to walk you through it. We'll take a look. You can come in and see if there's any, lacerations on the lip, the gums, any fractures, the bone. See whether or not they've had a concussion or have anything else they need to see another type of provider for follow-up or anything like that. If they're chipped, to kind of determine whether or not, if the baby tooth is chipped, we fix it or not, how deep the chip is, sensitivity, if it's loose, if it's mobile, things of that sort. If it's chipped to the nerve, it may require other procedures to be done. If they're adult teeth and they get avulsed, they get knocked out, then you want to put it right back in or keep it in the mouth somehow and call dentist or emergency line at the hospital. They may have a dentist to see if they can place it back as soon as possible within an hour, and call splint it, kind of hold it in place, and then, follow up with your dentist. But speed is important. And, I wouldn't wait, even if it's late at night, call someone, see if they can come and take care of it. Because if the longer you wait, longer than an hour, it decreases the likelihood of it, staying and you can have complications with that tooth in the future.
And I think that's what a lot of parents don't feel. They feel like don't want to bother a provider. But I mean, I think the vast majority of offices have an after-hour call service line where we will answer questions or potentially go in and see patients if needed. I mean, I think we're here to provide a service, and that's part of the service that we offer.
Absolutely.
One of the things that back in my practice days, a parent would say, I'm scared to put the tooth back in. What should I do? You know, that's what you said.
I mean, I always tell them, you may be a little scared, but it's going to be for your child's well-being.
Right.
He might not like it very much, but if you want to potentially save this tooth, you need to do everything in your power to be able to make it as successful as we can. And part of that involves you putting the tooth back in the socket.
Right.
And if you don't feel comfortable, find someone that can help you do it.
Right. And I
Don't
guess
put it in water though. Don't put it in water.
No water.
Don't rub on it. Don't kind of wipe it with a napkin. Nothing like that. Just put it in and bite on a towel for a little while and just hold it in place best you can until you can get somebody to kind of put a splint on it.
That's the point I was just getting ready to make. Don't put it in water. A better medium to put it in if you don't have anything available would be milk. That's what I would put it in milk and take it to the dentist and for it to be replaced. Okay. So that's managing avulsions. But sometimes you have falls, like bicycle falls, running into doors and things like that. And you get lacerations to the tongue, lacerations to the jaw and the lip. So what do you say to the parent if they have a child that has a laceration?
Well, I think first and most importantly is that they get somewhere, either our office or emergency room, to be assessed. For me personally, I feel completely comfortable suturing or putting stitches in anywhere in the mouth. Once it crosses the line where your lip and your skin connect, the vermilion border, I tend to definitely refer to an oral surgeon or a plastic surgeon or ENT for them to do that, because I want to make sure it's the most cosmetic result. They get the most cosmetic result as possible. Sometimes if a tongue is really lacerated, I don't feel comfortable doing the tongue too much. I'll send it to
It heal well without suturing, honestly.
Yeah, but the vast majority of the time, if it's just like a laceration, like on their gums or their cheek, I assess it, and if the need is there, I will place sutures. But it's not like Dr. Chan said, it's not extremely common that we have to place sutures. The oral cavity heals relatively quickly. It's a nice moist environment, so it's good for things. And place them on antibiotics depending on the severity of things, and just give parents the post-operative instructions, and hopefully they follow them appropriately.
Okay. And the lip and gums and everything that looks so different than any other place in the body when it's injured, that sometimes parents get really freaked out about the color. Like they'll look yellow and pink and green and white and all these different colors that just seem odd. And I always tell parents, like, that's just part of that injury. I mean, there's fat, there's muscle, there's blood vessels, there's salivary gland. All these things look different when they're injured. All different colors, all different, they all just look different. So don't freak out. You don't have to necessarily go to the emergency room for everything, like lip bites after a dental office visit.
Right.
We're always here to kind of answer your questions, text, email, something like that, kind of save you some trips to the emergency room that aren't necessary.
Okay. From the preventive side of the house back to restorative, how important are sealants, and what are sealants and how important are they?
So sealants are a protective coating that goes on molars of teeth inside the grooves to help prevent food from getting stuck in those grooves and causing cavities. Sometimes, especially adult molars, the grooves can be very narrow, sometimes even more narrow than the bristles of small little bristles of a toothbrush. So it's hard to get in there and to get the chips, the crackers, the gummies, things like that can get stuck. And it just seals it, almost like sealing your driveway or sealing your deck. It just makes food just slide right off. Very beneficial, very helpful in preventing cavities. And you typically do it once new teeth come in, like the first molars come in around 6, second molars around 12, just to prevent cavities. Those will be there forever. And I'm a huge fan. I do it as much as I can.
I love a good sealant. That's probably what I comment the most rewarding of my staff is when they do a good sealant. I'm like, we're preventing cavities.
Yes. You always want to know who did them. Who did these sealants?
We don't want to have to treat this tooth in 2 or 3 years.
That's right.
And and when you go in for your cleaning appointments, the dentist is going to check the integrity of those sealants and then reapply them as needed. Typically, a good sealant will last 2 to 3 years. Most insurance companies will pay for sealants every 2 to 3 years. But if they last longer, we'll fix them whenever they start to deteriorate. But yeah, it's something you definitely I would recommend getting done because it dramatically decreases the risk of getting cavities on those permanent teeth on the biting surfaces. Biting surfaces only, and you still have to floss, you still have to brush appropriately, but those grooves are much less likely to get cavities if they are sealed.
Right. All right. Well, thank you. Well, definitely that first molar, because I think that tooth has a higher percentage of decay than the other teeth if you look at the population. So yeah, it is pretty important. In our first introductions, we talked about treating children with disabilities, and that falls into the realm of the pediatric dentist. What can you say to our viewers about treating children with disabilities?
I mean, from a pediatric dental perspective, that's what we're here for. When we're in residency, we are trained to deal with patients with a wide variety of special needs that we're able to treat throughout their lives. Down syndrome, autism, cerebral palsy, mental retardation. And most often, we are the dentists who feel comfortable enough to be able to treat the children. If, at some point, they aren't cooperative enough for us to do the work in the office, it might require a trip to a surgery center or the OR for us to be able to use general anesthesia to have the patient put to sleep. We do that on a regular basis. I say the vast majority of pediatric dentists take patients to the operating room and do work under general anesthesia. It's a very safe and controlled way of getting the child the care in which they need, but it's also much less stressful on not only the patient but the parent, because the parents aren't having to deal with the repercussions of a patient having a traumatic experience and being afraid of coming to the dentist in the future. I definitely think we need to do as much as we can to kind of keep those patients as healthy as possible, because it's already a very trying life for them. There are other medical issues that they're having, and if we can keep their dentition as healthy as possible, it only makes their overall care and well-being easier for the parents.
It's a I don't know, it brings a lot of joy, right? So I mean, sometimes, especially the first time they meet, first time they see you, and they be scared, may not exactly know what's going on in their environment, because their reality may be a little bit different than how we process things. And being able to connect and them to trust you, and then you can kind of see them in their own way light up, and being able to treat them, because a lot of times the parents too, like what Dr. Jackson said, they may not have been able to brush their teeth like at all. Maybe they might be combative. They may not like anyone close to them. They may not have figured out exactly the best way to approach them with brushing. But figuring out, I think for me, I feel like every child kind of has their own little Rubik's Cube. You know what I mean? Kind of figure out what works for them, right? Do we have the lights halfway on? Do they need to be lower for this patient? Does this TV need to be off or on? This particular show at certain volume? Do we need to be laying on the ground? Do we need to be on the couch? Do we need to be in the chair? So many different things that each child may need, who may have special needs, that once you figure that out, the parent can mimic that as best they can at home. And it's all of a sudden opened up a new avenue of health and connection and things like that. So it's like, it's really amazing. And it's kind of, like Dr. Jackson said, it's kind of one things that we are trained to do. But I feel like the type of people who want to do it is like it's the type of thing that they're supposed to do. Like, we feel like this is the type of people that we are to be the ones to do this. That's why we chose this. And so, yeah, it's kind of some of my favorite parts of the day.
Yeah. And then when it comes to treating them, I know parents may feel like access to care might be an issue. Mm-hmm. Even parents in different socioeconomic statuses, access to care is a huge problem that we have in America. And I know it's different from state to state depending on the type of federal assistance programs that each state has. a lot of times I think parents might have state insurance, and for an adult, oftentimes dentistry isn't covered. But I think the vast majority of states have dental coverage for children if they have state insurance, and it's just a matter of getting those special needs patients into the dentist because it's a covered benefit. Getting patients who might have Medicaid or state insurance into the dentist because it's a covered benefit. Just utilizing those services that you have available to you to help your child stay healthy. It's what we really want to stress the importance of.
Absolutely. Because sometimes, because they can't express all the time if they're in pain or something's bothering them or they have infection and things like that. And then we see them when a good amount of their teeth are decayed, and we're wondering, why they're lashing out a little bit more, why they may be uncomfortable more, not allowing you to do the things that they let you do, like maybe brush their hair, brush their teeth, put clothes on the same way. And we take a look at their mouth and say, oh, wow, they've been dealing with this pain and not been able to express themselves. And so, like Dr. Jackson said, just kind of, because you may have this benefit to you, I say just, be able to utilize it as much as you normally would in regards to coming every 6 months, allowing us to take a look at it. Because the more they come, the more comfortable they are. And we'd be able to maybe even do things outside of the OR if possible. But and utilize the services that's available. If you don't know the services, there are definitely means to finding out what those services are. And just give us a call too, because we can help direct you.
Okay. All right. Thank you very much for that great discussion. There's a question that has come in. And the question is there a certain age that you recommend using teeth whitening products on children, or is it better to use natural whiteners on children's teeth? Are they too young?
My recommendation is I don't recommend parents bleach their children's teeth until they have a full complement of all adult teeth that are completely in. I had a patient that the parents bleached. They bought some bleaching agent online, and the patient was like 7 or 8. So, they have these really white front 4 teeth. And, when they came into my office, they were like 11 or 12, and all the rest of their teeth were a completely different color. So I always stress the importance of, you want to make sure, if you want to bleach the children's teeth, you want to make sure that they're completely in, because their teeth are naturally different shades from the front to the back. But also when they come in, you don't want the front teeth to be extremely white and then the back ones, and you're never going to be able to match the two up. That's just my personal recommendation.
Yep. And then sometimes, depending on the amount of whitening there are in different kind of companies and everything, sometimes it may increase the amount of staining that may happen on the teeth. It may all of a sudden make them seem a little bit darker or hold on to stains a little bit more. And then sensitivity. I mean, if you get kind of used to, putting these in, if they're office grade or depending, again, we don't know how strong they are, kind of whitening chemicals on your teeth, then they can be sensitive. And the more you do it, the younger you do it, the more likely they'll be sensitive forever. Then you're almost having to, use fluoride rinses or do something to like decrease the amount of sensitivity, because it can be debilitating to have all your teeth just hurt, so I would be careful.
Question from the endodontist. Knowing that the bleaching agents basically are formulations of peroxide, is there any, and they all come in various strengths, is there any pulpal damage that one might get from the inaccurate use of these bleaching agents?
I mean, I always recommend parents, if they're interested in getting them bleached, I want to make sure that they don't have any active decay first and foremost. But also, as if they're healthy teeth, personally, I don't know of any long-term pulpal issues that you would have from bleaching. There is, like Dr. Chan says, there's definite increase in sensitivity. I mean, and like you said, you want to do something with additional fluoride that's going to decrease the sensitivity that they experience. But from a long-term perspective, I personally haven't seen any endodontic issues.
Okay, all right. As we're moving toward the end of our hour, I'd like to talk about, you did mention it, Dr. Jackson, but the disparity in healthcare for children. You did mention Medicare and the coverages, but What about insurances and insurance coverage for children? Is there any, and the disparity here that you all may address?
Yeah. So insurance doesn't make it too easy all the time. I would say that. I feel we're finding more and more providers, keen not to want to take insurances, and mainly because of the reimbursements or I guess, quote unquote, the headaches that we sometimes get from the insurance companies. And a lot of times parents, families may think, okay, this dentist is, the dentist is doing something different, right? So it's like, it's expensive because of what the dentist is doing, or what's happening with their insurance is something that, the dentist is doing. But it's like, the insurance companies do not make it easy. They do not want to pay money, right? I mean, it's a business. So they make it a little bit difficult to get treatment done. And then also for a provider perspective, sometimes they can, reduce reimbursements, the money that we get when we send a claim to them, reduce it just out of nowhere. And so a lot of dentists are kind of getting off of insurances, which kind of leaves patients with finding new dentists every once in a while. And you may be the only dentist that may take all the insurances. And you kind of, if you're taking insurance, you're almost making it a point to say, it doesn't matter what the insurances are doing, I'm trying to help these patients. So it can make it a little bit difficult. It can be very expensive. And so, and even still, there's still not enough of us pediatric dentists. And so you combine that fact, not enough of us, and even less are taking insurances, it can be a little bit of a problem. So it's, if general dentists are working on kids, is they also have to be as educated and understanding as us at times to treat them in ways that we would likely treat them, because sometimes we get them, and there's a lot of things that maybe not considered that we would consider.
Right.
So
Okay.
That's all well said, Chris.
We're on the same team.
Well, at this time, Dr. Jackson, I want to thank you for this excellent discussion, this conversation that we've had. We've covered a number of topics, and dealing with oral health, your pediatric population. And so you've done an excellent job on addressing these topics. And you shared some very important points on the caring of your teeth and provided some great information for our viewers tonight. So I want to thank you for sharing your expertise. And I want to thank those of you who attended. And I hope that you've gotten some points that you can take back in caring for your children's teeth, or your grandchildren's teeth, or your great-grandchildren or godchildren. So all in all, to address the need for good oral health care for our young patients as they grow to become adult patients. So it's been a delight to be with you, and I hope that you will join us again sometime in the future as we prepare more webinars for your educational and knowledge benefit. And with that, I bid you a good evening and good wishes to all. Thank you very much.
Thank you.
Thank you.